Hello again. Today I'll try to show two cases. This is the first case to start with. This is a frontal chest radiograph on a 54-year-old male patient. One of the important things to evaluate is the contour of the central structures, the mediastinum, hyla, and heart. In this case, you see that the mediastinal contour bulges in this location. A little bit of anatomy. This is the trachea, this is the carina, and this is the right main stem bronchus. The tracheobronchial angle is where a normal rounded or oval structure lives. This structure is the azygos vein. So one of the thoughts that could cross your mind is that this could be a distended azygos. However, in this case, this is not. The bulge is protruding over the lung parenchyma in a degree that exceeds the expected azygos distension. Practically speaking, it's difficult to differentiate what is an azygos abnormality from a non-azygos abnormality if you cannot see the azygos shadow here. In an older clip, we discussed the azygos course and anatomy, and we also discussed the differential diagnosis for its dilatation. So if this is not an azygos abnormality, what else could it represent? Generally speaking, this abnormality could be arising from the mediastinum, from the pleura overlying the mediastinum, or from the lungs. Mediastinal abnormalities would include something such as lymphadenopathy, which could be due to an infection, a neoplasm, or an inflammatory condition. Pleural abnormalities would include pleural metastasis or fibrous tumor of the pleura. And lung abnormalities could be benign or malignant, for example, lung cancer. CT scan of the chest on the same patient. The CT shows these rounded soft tissue densities within the mediastinum and in both hyla, consistent with enlarged lymph nodes. This paratracheal lymph node, for example, is large and homogeneous without low density, so it means that there is no obvious necrosis. To clarify things, this tubular structure that's running up and down along the side of the spine is the azygos vein. And as you see here, the azygos vein goes anteriorly to empty within the SVC, which then empties into the right atrium. The opacity on the chest X-ray that appeared as if it is arising from the azygos vein area is a lymph node as well. So this is the lymph node that you saw on the chest X-ray, and you could imagine why it looked like a contour abnormality of the mediastinum. The differential diagnostic categories for enlargement of lymph nodes would mainly include metastasis, lymphoma, sarcoidosis, and infection. Knowing the patient's clinical information, such as if the patient is symptomatic or not, if he has fever, if he has a primary tumor, would help differentiating those. Although this rule does not apply to all cases, if this were to be an infection or metastasis, you'd expect a large lymph node of this size to be necrotic in the center. A common and famous infection to give you lymphadenopathy, for example, would be tuberculosis. When TB reaches this size, you typically see necrosis in the middle. Knowing that the patient was relatively asymptomatic and the lymph nodes are homogeneous, this would leave you with lymphoma and sarcoidosis. Now, out of all of those categories, the category that typically gives you bilateral symmetric lymphadenopathy in the hyla is sarcoid. Using bronchoscopy, one of those lymph nodes were biopsied, and this was a proven case of sarcoidosis. So we learned from this case that one of the things that you should assess on chest X-rays is the contour of the mediastinum. We also learned that the azygos lives in the right tracheobronchial angle. A bulge in this region could be due to a dilated azygos or due to other structures. By other structures, we mean mediastinal, such as lymph nodes, pleural, or lung parenchyma. Common categories for lymphadenopathy of the mediastinum would be metastasis, lymphoma, infection, and sarcoidosis. When lymph nodes are large, in the cases of infections such as tuberculosis or metastasis, you'd expect to see some necrosis. The classic entity to give you bilateral symmetric hilar lymphadenopathy is sarcoidosis. Although the others are not excluded, you'd know based on the history. That's it for this case. Now let's go to the second case of the day. Now this is another case for seniors, but hopefully juniors would learn one or two new things. This is an adult male patient who presented with heart block. This image is an MRI image of the heart, and you're looking at the left ventricle in short axis. So this is the left ventricle, this is the right ventricle. The left ventricle looks like a donut, an image that's very familiar if you think about what we do in nuclear cardiac imaging. When you do cardiac MRI, you could image the heart in different views and planes. We'll concentrate on this plane here, which we call the short axis plane. You could also image the heart using different sequences. Remember, with MRI, you could use T1 or T2 acquisitions. And when it comes to cardiac imaging, you could use modification of such techniques. The view we're looking at is a short axis T1 view after giving intravenous gadolinium. So we're giving intravenous contrast, we wait for 10 minutes, and then we acquire this image. This is why this is called a T1 intravenous contrast enhanced delayed gadolinium or late gadolinium enhancement. So this is known as delayed DGE or late LGE gadolinium enhancement. Lots of physics is involved to understand this, but let's simplify the concept of doing this image. The way this sequence is done is for the normal myocardium to be pitch black. It should be extremely dark. The myocardium, which is normal on such an acquisition, should be darker than an envious heart. And the reason we wait for 10 minutes after giving intravenous contrast is to give chance for the contrast to diffuse into abnormal myocardium. So in this 10-minute post-intravenous contrast T1 short axis LGE acquisition, everything should be black. An area of abnormal myocardium, whether due to acute edema, scarring, or infiltration, would give you brightness. Here you see the dark normal myocardium in contrast to the normal white cavity containing blood. Now that we agree that the normal myocardium should be black, the normal blood pool should be white on this sequence. This here is abnormal. So you have a focal area of delayed gadolinium enhancement within the left ventricular myocardium. The next step is to describe where in the myocardium do you see this abnormality. A little bit of anatomy to describe that. The inner part of the myocardium is called endocardium. The outer part of the myocardium is called epicardium. And the middle part of the myocardium is called mesocardium or mid-myocardium. Another anatomical fact is that the coronary arteries supply the myocardium from outside inwards. A fact that means that if you have ischemia or infarction, the most and the first affected area is the inner area, the distal area. And that's the part of the myocardium that we call endocardium. So in cases of enhancement due to infarctions, you'd expect the endocardium to be involved. And that type of enhancement could extend to involve variable thickness of the myocardium outwards. We also know that different areas of the left ventricular myocardium are supplied by specific vessels. So you have vascular territories. For example, this area here is classically supplied by the left anterior descending artery. The lateral area is classically supplied by the left circumflex artery, and so on. So specific regions by specific vessels. This is the general rule, but remember that there are lots of variabilities when it comes to the vascular supply of the left ventricle. We'll talk about that later. From all of that, we know that if you have ischemic type of enhancement, such as enhancement from a myocardial infarction, such an enhancement would stick to certain roles. First, the endocardium should be involved. Second, it should be in a vascular distribution. So ischemic enhancement, you should have involvement of the endocardium and a vascular territory. That's compared to non-ischemic enhancement from, let's say, infiltrative disorders, where it's not sticking to these rules. So in cases of non-ischemic cardiomyopathy, such as amyloid or sarcoid or others, you'd have sparing of the endocardium or involvement in a non-vascular distribution. Now that we know what to talk about, you have an area of abnormal delayed gadolinium enhancement in the left ventricular myocardium. The area looks like a focal patch that spares the endocardium, so this is fitting with non-ischemic cardiomyopathy. Here's a different slice. This is the left ventricle, this is the right ventricle, this is the myocardium, which is dark and normal apart from here, where you have an elongated large patch of non-ischemic enhancement since it spares the endocardium. The appearance of multifocal patchy non-ischemic enhancement of the left ventricular myocardium would raise a few possibilities. This appearance, when acute, raises the possibility of myocarditis, and if chronic, raises the possibility of sarcoidosis. With acute myocarditis, for example, from a viral infection or a drug reaction, the presentation would be more dramatic. Typically, those patients would have normal coronary arteries but would have elevated cardiac enzymes. This patient's presentation was chronic and different. The patient had arrhythmias and heart block, and this favors sarcoidosis. This was a proven case of sarcoidosis, and these area of enhancement represented infiltration by non-caseating granulomas. In many patients with cardiac sarcoid, the patient is asymptomatic. However, in some cases, these granulomas may be symptomatic, since these granulomas may lead to arrhythmias and heart blocks, and this is what this patient presented with. So we learned that with cardiac MRI, you could image the heart in different planes with different colors. We're a bit more familiar with the short axis plane of the heart, where the left ventricle looks like a donut. We're also more familiar with the late gadolinium enhancement sequence, where you have myocardium that's normally dark. If you see brightness in this sequence, this means abnormal enhancement, and this could be due to ischemic or non-ischemic causes. MRI is a great technique in differentiating both. If it's ischemic, it involves the endocardium in a vascular distribution. If it's non-ischemic, it may spare the endocardium and or involve a non-vascular distribution. When you have multifocal patchy non-ischemic enhancement, think about myocarditis and sarcoidosis as two good possibilities. And yes, one more final thing. This is the same case that I showed you the chest CT on just a while ago. So this is today's two-in-one kind of case. Thanks for watching, and we'll see you with more cases later.